är dags. Now it's time to continue. Let me just say that the next speaker says Dr. Pepe Catalan.
I will explain.
No, and I was concerned. I didn't want to use your name Pepe because I thought that was kind of a more nickname family name. So that's why I introduced as José Catalan. But anyway, we'll now continue with living and aging with HIV, and Pepe Catalan will then be the presenter.
Thank you. Thank you very much to you, Lena, and to everybody for inviting us to come and share these experiences with you. I'll explain the name question. I come from Spain, so José is Joseph in Spanish, but Pepe is Joe. It probably comes from the Italian Giuseppe. Spain controlled much of Italy for about 300 years. So I think that's where the link is. So Pepe is the same. People often say to me, "Are you married to José? Is she your wife?" So no, it's the same. Okay, so that's me. I'm a psychiatrist, and I've run the services for HIV mental health in a big centre in London, probably the largest in the UK for HIV, and I developed the mental health services there. I'm now retired clinically, but I'm doing research and writing still, so I don't see patients now. But we had a very large service for about 26 years, providing assessment and intervention, working with the general physicians and nurses as well. And what I'm going to be telling you about is some of my experience there and subsequent research we've done at the same time and a bit later, hence the two topics. Do stop if what I say is not clear or if I talk too fast. Now, what I want to tell you about is something about how the picture of mental health difficulties has changed over time, at least in our experience. Then something about depression in HIV, and does it matter whether people are depressed or not? And then something about the quality of life in older people with HIV. That's going to be much of the focus of what I'm talking about, including what people tell us they do, older people, they tell us they do to cope with aging with HIV. So that's the menu for today. The first part, looking at the changing picture of mental health in HIV, is based on a paper that we published a couple of years ago. The paper's here. You can access, I don't think it appears there, but you've got copies. It's open access, so you can print it. But basically, this is the only study I know there is where we've followed up, we've looked at people over 24 years, not at the same people, but looking at referrals to the mental health service at different stages since 1990 to 2014, and looking at the diagnosis, the problems that they present when they get referred to us. So it's not a reflection of what's going on out there in the community or what the medics and the nurses are dealing with, is what gets referred to the mental health services. So they're presumably more severe, although there may be all kinds of reasons why they get referred, apart from being more severe. So I'll take you through it in some detail. Now, we're looking at 1990, 95, 99, 2005, and 2014. There's slices of referrals in those years to our service. And what you have on the left is the principal diagnosis. Some people may have more than one, but this is the main diagnosis, right? I'll take you now to the total referrals. In 1990, we had 123 people referred, 306, 360, 406, 490. So the number of people referred to mental health for HIV goes up in that hospital, in the big hospital. Now, I don't know the denominator. I don't know how many people with HIV there were. Obviously, they would be increasing as well. My guess is that the proportion has increased a little bit. It may not be as dramatic as it appears compared with all the people being seen. But so that's the first thing to show you that we are busy in that service. The second thing is the labels. And look at the percentages rather than the numbers. If you look at depression in 1990, 20% of referrals got the label of depression, 33, 34, 45, 47. So that label has gone up. Without going into details of everything, what's gone down is the acute illnesses, acute brain syndromes, mania, schizophrenia-like illnesses, dementias. That's kind of disappeared gradually. But it's the chronic, long-term problems, often meaning a lot of baggage from the past, which is now coming up as you're beginning to feel better physically. Lots of things keep reappearing. And the label depression is perhaps the short term that covers that, but we'll come back in a minute. But the message is, the picture's changed. People are not coming in a terrible state because they're positive and they're panicking. That's kind of disappeared as well. They're not manic, they're not psychotic, they're not demented, they don't have a brain syndrome in the hospital with PCP. They're coming with long-term anxiety and depression. And that's increasing. As you see, almost half of the referrals are like that. This is just looking at not percentage but numbers. The blue line is the depression. Look how the numbers, how they've shot up in terms of referrals to us. And what's gone down is the acute problems, as it were. In the last year, in 2014, we looked at substances, recreational drugs used by people. And many use recreational drugs. It might not have been seen as the main problem, but you can see what they were taking. Mephedrone, crystal meths, G, cannabis, cocaine. But the main ones that certainly in the UK, in London in particular, are very popular as recreational drugs will be mephedrone and crystal meths. I don't know whether this is the case in Stockholm. Do you have problems with recreational drugs of this kind? A little bit. It's a nightmare in London. And the problem with it is that it affects adherence, increases hepatitis C risk, etc., etc. But as you see, a huge proportion are using them. May not see it as the main problem, because only a small group saw it or was diagnosed as the main problem, but that problem is there. We also looked at people who had HIV and Hep C at the same time, trying to see if their diagnoses were different. They weren't. It's about the same. We thought that the Hep C group would have more depression, more anxiety. In fact, it's very much the same. There's no differences, which is striking. So they're just as bad, if you like, as depressed, but no more. Complex cases. Our service at that stage was very well funded, so we had psychiatrists and psychologists working together in the team. The psychologists were not in another building. They were in the same building. We interacted all the time. We had 2 or 3 meetings in the week when we talked about patients, shared patients, and so on. So a number of patients were seen both by psychologists and psychiatrists, not in the same day, not simultaneously, but typical case would be a psychologist sees a patient, refer to them because he's got some degree of depression, and then they realize that he's got suicidal ideas. So they worry, is this severe depression of the kind that antidepressants might be relevant? So let's get a psychiatric assessment. So they cross-refer to us. And vice versa. Somebody that I've been seeing with depression, maybe treated with antidepressants, is getting better, but there is a whole host of baggage issues that need to be dealt with, and pills will not deal with that. You need psychological therapies. So as they're beginning to improve from their acute depression now, then they get referred to the psychologist. So those complex cases were involved in both. Again, we had 174, which is quite a high proportion. It was 40% of all the people were being seen by both. And as you would expect, the labels are, in the psychiatry group, more depression and more anxiety in the psychology group. But the theme I was going to stress here is how, by working together, we were able not to give double messages and say, oh, don't take tablets, don't take antidepressants, that's bad for you, you need therapy, or vice versa. We're working very jointly together, both psychologists and psychiatrists, and that was really great beneficial consequences for the patients. That could apply outside HIV too, but often, certainly in the UK, services are very split, and psychologists and psychiatrists sometimes don't talk to each other, they're in different buildings, they get paid differently, they're managed differently. It's a nightmare in that sense. So working together is difficult. Here was, for a period at least, was very easy to do that and to work together effectively to the benefit of patients, of course. So you saw there that depression was mentioned as the most common presenting diagnosis now. So how common is depression? This is difficult to read, but doesn't matter because in some ways it doesn't make sense. This is part of a systematic review that Lorraine and I and others did, looking at all the literature on HIV and depression when it was published in 2011 and the years before, trying to see what conclusions we could reach about how common it was. You couldn't reach any conclusion because it went from 0 to 80%. And much depends on, first, what you call depression, how you measure it, what instruments or what method you use, what population are you dealing with? Is this people who've been diagnosed for many years? Is this people who are acutely ill? So very confusing picture. So you couldn't really say 20%, 30% from the published data would tell us how common depression is. We know it is common, but it depends where you are and how you label it, how you diagnose it. So part of that issue is depression the same as being unhappy? We now got into a world ourselves in our developed country society where we like giving diagnosis to everything and to everybody. And sometimes what is seen as depression may not be depression, maybe a normal way of dealing with whatever problem it is, trauma, dealing with impending bereavement, past bereavement. Some of those issues may not be illnesses in the sense of depression, but we kind of medicalize it sometimes. And it's not easy sometimes to decide, is this something which is normal and people will just deal with as they've done in the past, with support from families, friends, relatives, etc., and it has a natural history, or is this something that we need to intervene, the professionals come in and do something, or the support groups? So all the time when we're talking about depression, we need to be very aware. When we talk about psychiatry, we need to be aware that sometimes we may be overextending ourselves, and what we're doing is not necessarily right. We may better rely on support groups, on families, and so on, to provide help and support rather than immediately reach for the prescription pad or for the therapy approach. That may be relevant. I'm a psychiatrist. I've done it all the time. But I think it's about having that sensitivity and that judgment about deciding what is unhappiness, which you don't want to medicate, and what is an illness or something that may benefit from intervention, even if you don't use the word illness in that sense. Okay. Now, let's move on. There's a big study done in the UK called the Astra study, looking at people who are positive and who are on antiretrovirals, on ART. And you see it's more than 3,000 individuals. And in this study, they were looking at the relationship between mood and a number of use of medication and other variables. So just focus on this instrument called the PHQ-9, which let's just look at this section here. The higher the score, it goes from 0 to 27, the more depressed you are on that. It's a self-administered questionnaire that people hand out. And as you can see, the very depressed will be the last two groups. So in this population of over 3,000 people with HIV on treatment, you find that the very depressed group is 6.4 of the whole population, 7.7. So you can see how it decreases in a way with severity, but you still have a significant group. Now, how does that compare with the general population out there? Difficult to be sure. There are a lot of studies from other places using it in Germany and so on. There's one from England, 7%, US 6.8, because these are people who are not necessarily comparable. They may not be gay men or former drug users, maybe anybody in the street. But it does suggest that that overall picture of more than 10, which would be the cutoff for being depressed, on that instrument is about 27%, more than a quarter, compared with a much lower figure there. You can do the same with anxiety, with suicidal thoughts, and so on. But you can see it suggests that using a particular instrument, comparing with the general population elsewhere, people are more depressed. Okay? There's more people with depression. But does it matter if people are depressed? Okay, they're unhappy and depressed, we want to help them and make them feel better, whether this is with medication, with psychological therapies, with support, etc. But beyond that obvious element, what do we gain by dealing with depression and treating it? Coming back to that study, this is looking at non-adherence to antiretrovirals. Remember, all these people, in this case it's nearly 3,000, not the whole sample, are on antiretrovirals. And here we're looking at non-adherence, meaning by that, that person has missed 2 or more consecutive days of ART on 2 or more occasions in the previous 3 months. So that's described as non-adherent. And then you look at their mood when they come, and what you can see is that the proportion of non-adherence goes up with depression. So that if you have the highest score on that instrument, 27, 25% are non-adherent. If you have 0 to 4, is 7% or thereabouts. So there's a clear link with how depressed you are, how unhappy you are, and how bad you are at adhering to treatment, how you're taking your medication. It's very neat there, you can see, and that's significantly different. There's other indicators too, but that's the one I want to focus on. What about non-viral suppression of the viral load, which is another way of looking at non-adherence? And again, this is using clinically recorded viral load at the time of the questionnaire. And again, you find exactly the same. The proportion of non-viral suppression is, 18%, something like that, in the most depressed group. So it's a clear link with, depending on how depressed you are, the higher the score of depression, the greater the likelihood of that person not being suppressed virologically. It's the flip side of. This is virological rebound, having suppressed and then coming up again. The same theme. If you look at the middle section here, again, as you go up, the proportion of people who are rebounding 25% of those with high scores, the viral loads come up again because they're always not taking the medication. So a clear link. All these things have impact on your health, clearly, and on your life. So clearly depression is relevant. There's a clear link between the two, but that's one way of getting into the adherence, viral load rebound, everything else is focusing on the mood aspect of it. This was, again, parallel. This is looking at how many people knew their personal viral load level. And if you look at here, is the same story. People with a score of more than 10, which are depressed, 23% didn't know. It's inaccurate. But if you are not depressed, if you have less than 10 points, 13%. So again, your knowledge of what your viral load is, how informed you are, how interested you are, if you like, in your health, again, is linked to your depression. If you're very depressed or high level of depression, they're all the same, different ways of looking at the same issue, if you see what I mean. But essentially, it's telling you if you're depressed, your health is going to deteriorate. So there's some value then when I say, is it worth thinking about identifying depression? Clearly, there's an opening there.
May I just
make
a comment?
Yep.
I think it's really intriguing what you're talking about right now, the clear association between depression and the viral load, adherence, and so on. And we neglect, I shouldn't say we, the healthcare system neglects mental health.
Looking at that side of it.
And then the doctors and nurses get very upset when people don't take their medication. Well, maybe you should start asking questions about their mood. We'll come to that in a second, to the questions as well. This is part of another study related to the Astra study, which is looking at negative individuals. So let's look first at the bottom one, which is, this is the Astra. So this is unsafe sex. This is people who had no sex. These are the positive ones. So this is the percentage of more than 10, in other words, the depressed group on that questionnaire. If you had no sex at all in the positive group, 30% are in the depressed group. Condom-protected sex, they're less depressed. But one unsafe encounter, more than 2, depression goes up. So unsafe sex is also related to your level of depression in the positive group. Interestingly, in the negative group, it's the same. You can see the negative group there, it goes up with mood. As the more depressed you are, the more likely it is you have unsafe encounters. Interesting, the first group, which I thought somebody might ask, if you're not having sex, you're actually quite depressed in that group, more than the other one. It may be because you're so depressed you don't have sex. You're not interested. You've gone off the idea. There may be a link between the two things. And the same interesting in that one, people who are positive and didn't have any sex in the period in question, the 3 months before, there may be an element of being quite depressed. They're almost as bad as the ones fully...
but no sex is not necessarily a choice.
Exactly, absolutely. But linking it with mood, you can see that because they're so depressed, there's all kinds of factors in it. But I think the theme is, if your mood is bad and it's worse than the day before, as it were, clearly something is going on there that may put you at risk too. Which we knew, but it's so clearly laid out there.
Maybe no sex is making you depressed.
Yeah, absolutely. So sex which is safe would be the good thing. Yeah, it will bring it down. You see the condom-protected sex, there you are. It goes down. Yes. You're worried. You're concerned.
No, what I was thinking, isn't it because when you feel better, you also make better choices?
Yeah, absolutely. There's so many factors in it. Now, you were asking, Lena, can we ask the question? This is a study that was produced not far from here in Aarhus in Denmark. And they looked at a clinic where people with HIV were coming along, and they did an assessment using what they call the HOLI questions, which I'll show you in a minute, and a standard assessment of depression. And they were able to conclude that with those 2 questions, a yes to one of those 2 questions, which I'll show you in a minute, you had a huge sensitivity and reliability. So it was a very good way for the medics and the nurses to identify depression. And those are the questions, which is nothing. It's not complicated questionnaires and forms and so on. Just ask, in the last month, have you felt bothered by feelings of feeling down, depressed, or hopeless? If the person says yes to that, okay, we focus on that person. Or if they say yes to the second one, in the past month, have you often been bothered of having little interest or pleasure in things? Enjoyment and being happy. Now, a yes to either of those questions means we need to worry about this person. We need to focus now. What else is going on there? And it's very easy, very simple questions. But as I was saying earlier when Lorraine was talking, You're only comfortable as a medic or a nurse or a community nurse, whatever, or a volunteer, asking those questions if you know you can do something about it. If you know that, okay, if this person is depressed, my God, he or she might be suicidal, where do I go next? What do I do next? So you need to have a structure, a backing, a support structure that will allow you to... The medics may be very sympathetic, but they say, oh my God, I can't possibly ask every patient this question, because then I'll have 20 patients every morning that I need to refer. So it gets complex. But it's very easy to begin to identify, and these simple things, these woolly questions have been used in other settings in the UK, in antenatal clinics, in other settings, please.
Those are the two main criteria for the DSM.
Exactly. Exactly. So it's quite sensitive. But I think the advantage of this is that it's not a sort of 20-question questionnaire or sitting down with a psychiatrist. It's very straightforward as a screening instrument. Okay, in some cases it may be wrong, but in most cases it's right. And it's very easy. But as we keep saying, you need to know what to do after you've got a yes or two yeses. So what do you do? Again, I won't go into details of it, but the nice organization in the UK is National Institute for Clinical Excellence. There's a national body which is independent from the government, which looks at evidence for treatments of all kinds and produces regularly evidence on what should be used for IBS, what should be used for this, for that. And regarding depression in people with physical illness, there are a number of, they update these things all the time. And the theme really in this is that there's no one answer. You've got a stepped care model. To begin with, you do your screening, and you may then provide some basic support and listening and try to explore what's going on in that person's life. Okay, and I'll see you again in 2 weeks' time, say how you're doing. Then you see in 2 weeks' time, they're still feeling bad, then you may increase the amount of input. You may say, well, can you see the psychologist working here with me in the practice? Or shall I refer you to the local NARC-SARC support group? And then you keep increasing, but you need to be involved. And it's not a question of saying, oh, everybody has antidepressants then, or everybody has psychological therapy, psychoanalysis, CBT, etc. You're sort of all the time monitoring, and obviously if somebody is very, very depressed, you may go step to the top, straight to the top. But the idea of stepped care, you can Google NICE guidelines, all these things are available. You may have a similar thing in this country. But really the theme is, okay, think about it, assess, and be prepared. Have a structure so that to begin with, you do something fairly minimal intervention. But then as things move on, you go somewhere else and you keep increasing. So you need to have your links with services nearby, et cetera. So it needs planning, it's thinking ahead. It's not that complicated. If you wanted more details about all these things, you can email me at some point and afterwards and send you information. Okay, that was on the depression side. Are there any obvious issues that come up in what I've been saying, please?
Yes, I would. You're saying older people living with HIV.
We're coming to that now, yes.
Yeah, we usually here in our organization we talk about people who have lived with HIV for a long time,
yes.
that not necessarily being old in age, and then also older people that perhaps have not have HIV a long time. But do you make a distinction, or you're talking about physically older?
I think what's happened in the UK is that people have done a lot of research. Much of the research is on people over the age of 50. And many of those may have been diagnosed yesterday, but many of them may have been diagnosed for a long time. So I think the age boundary has been the key, at least in research, looking at people of the age of, that's what's called older, over 50. Most of us are way beyond that line. And then within that group, people will look at length of diagnosis. Is that relevant? Is it worse if you're over 50 and you've been diagnosed for another 30 years, etc.? So, but I think we tend to use the idea of age as the easier to measure thing. But the two things interact, obviously. So I'm now moving from the depression side to this one, which is the quality of life in older people living with HIV. I've been involved in a number of studies looking at this population and on these issues, and I'll tell you in some detail. Now, really, the question is it all bad news? Because we hear all the time, oh my God, all these people getting old with HIV, what a terrible problem. What are we going to do with them? Hang on, are they a problem? This is success, it's a sign of success. And we mustn't necessarily see it as something to get rid of or something which is problematic. Do you see what I'm trying to say? People doing research or people funding these things do what in the UK is called shroud waving. Shroud is what you put around the body when somebody's died, right? When you bury them. Shroud waving is sort of look at all these people dying, all these terrible things, which we like doing so we can get funding. So medics get caught up into this kind of world. So when we hear, certainly in the UK, discussions about people aging with HIV, you're very tempted to fall into that trap of saying, oh, well, it's a terrible thing. All these old people with HIV, it's a wonderful thing that they haven't died. It's a wonderful thing they're getting on. Okay, they will raise another issues and we need to face the difficulties there. But it's not all bad news. That's not my theme. It may be bad news in many cases, but it isn't always. And we need to, certainly in countries which have access to treatment, it may not be the same in other countries where things are quite different. But here, we need to be very realistic and look at the picture, look actually what's going on, what is happening there. Okay, so is it all bad news? So what is quality of life? It's interesting that this term, which was there at the beginning of HIV, and I did some research on that, published some papers in the early days when there was no treatment. And the issue was, well, as there is no treatment, really what is important is quality of life. How do we keep people happy and contented for as long as possible? Now that all disappeared, but now it's kind of coming back again. And sometimes quality of life assessment is more interesting than the mood measures and everything else, and because in a way mood comes into it, depression and other things. It's a more global, broader way of looking at it, as you'll see in a moment. So what is quality of life? It's a subjective measure. It's not something, it's not like functional assessments, but how many stairs can you climb, or how fast can you run, or it's purely subjective, what the person feels his or her quality of life is. And how do we define it? Sit down for this. WHO has this very complicated label, or way of describing it. I'll give you a minute to read. Position in life in the context of culture and value system, goals, expectations. You see what it's saying, that there is no one quality of life, depending where you've grown up, depending where you are, depending what your family expects. So it's a very complex thing that has to do with lots of other factors. So you can't have a questionnaire that says that's it, or a reply. But the point to make is that it's a multidimensional. While depression is about mood, quality of life has lots of different areas in it that define the quality of life. And some of it may be how do you feel physically or psychologically, how much money you have, what sort of flat you live in, how many friends you have, all those factors come into it. But the key thing, as I was saying, is not a measure of functional health status. It doesn't tell you how fast you can run, how many steps you can climb, how many whatever. It's a subjective perception of a sort of context, really, in your life, which we all do in different ways. Although we take shortcuts and talk about depression or I feel anxious or whatever, but it's a broader picture here. Okay, so how do we measure it? There's two approaches. One is questionnaires, and there's millions of questionnaires, not millions, scores of questionnaires looking at how to measure quality of life. Some of them very long, and at the end of it, your quality of life goes down because you've been spending all this time thinking about yourself and how to do it. But there's instruments, and there's also qualitative. The whole area of qualitative research, for me, was new. I haven't been a quantitative researcher for years, and now I'm much more into qualitative research, looking at perceptions and narratives and descriptions of things, which again is a whole new area, which has become much stronger, certainly in the UK, in terms of physical illnesses in general, looking at the perception that the person has of how diabetes, cancer affects you, not just saying, oh, you're healthy now, you can go off. So those are the two ways in which we look at things, okay, in quality of life. Instruments, there are many, but the one we've used that I'll tell you about is a WHO Quality of Life HIV brief. It's an instrument that specifically focuses on HIV, and it's been validated in many places. It's a shorter version of a longer one. And the thing about this instrument is that it has a number of domains, a number of dimensions. It looks at physical health and has a number of 2 or 3 questions saying about how physically strong you feel, blah, 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 various things. It has psychological health, a number of areas there. Degree of independence, how you can get on with your life without relying on other people all the time. How many friends, how many people around you have, or what sort of relationships you have. Environmental health, that means your accommodation, the sort of place where you live. How comfortable, how safe do you feel in your flat? If you're going to knock at the door and invade you or rob you, etc. Spiritual feelings, how do you feel about meaning? It doesn't mean religion necessarily, but do you have a sense of purpose in your life, a sense of going somewhere, that things are happening for some particular reason in your life. And then you have a total score. So you can see how this is much more sort of subtle and looks at many aspects of a person's life as opposed to, are you depressed or are you not depressed? Or are you anxious, not anxious? That comes into it, but it's a broader way of looking at it, which also opens up possibilities for intervention. If you find that everybody is having problems with environmental health, living in terrible conditions, well, that's telling you that's an area we need to address, and so on, not just taking tablets. Okay, what do we know about then quality of life in people over the age of 50, to go back to that, living with HIV? There's now quite a lot of literature in the last few years. This is a paper that, one of the early ones that I published with somebody else, a social scientist, where we interviewed 10 MSMs over the age of 50. And without 50 to 78 was the range. And without going into all the details, essentially you ended up with two groups are you familiar with this? Yeah. Two groups of people who'd been positive for a very long time, had much more negative perception of their quality of life, and they've been struggling, had all the memories of all the people they lost, all their friends and partners. So it was much more, while others, especially the more recently diagnosed, even if they're older, had a much more forward-looking view. And in some of them I say, well, my life is better now than it would have been anyway, because now I go to the doctors every 6 months, I eat carefully, I exercise, my health is better than it would have been if I hadn't had HIV. So very interesting. For some it was a sort of positive thing. They're reframing it in a positive way. This is the same study done in Finland with an Italian researcher and Finnish people. Again, you see the title, I live quite a good balanced life now. You know, I have control of my life, I'm doing the right thing, and this is people of the age of 50 as well. I won't go into details of all of them. This is an interesting one, which is part of the Astra study as well. They used a different measure of quality of life, but the point I'm making is that the older people with HIV are a bit less over 50s. Their quality of life declines compared with the younger ones, but no more than the negative controls. The negative controls, as they get older, they go down as well in quality of life, but this was no dramatic difference. So it was as expected, if you like, as it would have been for some not positive HIV person. But let's come back to our own studies, the work we've done with Dana Rosenfeld, who was the lead researcher in a group of us, looking at HIV and later life study, what they call the WHOQOL study. And this was funded by the Medical Research Council in the UK. And this was a mixed method study, so we had quantitative questionnaires and qualitative narratives as well. So we were able to look at both sides of the picture of quality of life. We had 100 people. Yes, please, anytime. Yeah, whenever you like.
Okay, so I ask again then.
But ask me about this. Don't ask me what comes next.
No, before.
Yeah,
okay.
Please.
Well, I was thinking about another aspect. Of all of us living human beings have to make life choices, you know, regardless if you have HIV or not. And sometimes you regret your life choices, you know, or you're happy with your life choices. But I think that's an aspect with the differences. I saw an interview with myself when I was quite newly diagnosed. And then I said I was very happy to have HIV. This was in early 1990s, because now I know and I have all this, and it is, you know, and I have a happy perspective of my life, even though I thought it was going to be short. And now I sort of think that the life choices I made back then, knowing that I had to live this long, with those choices, you know. So had I known that I was going to survive this long, I might have made other choices. So this is, I think, is something that comes up with many people we talk to, that could differ a little bit, at least, from the general population. That, you know, you were expecting to die, and then you did choices that you...
That's a huge change, isn't it?
Like, for instance, instead of finishing university, you drop university or whatever you do.
Yeah, that comes up all the time, the sense of, you know, what do I do now with my life?
Yes, So,
thank you. Very relevant. These 100 people that we studied in this particular project, they were recruited from clinics, from volunteer organizations, from support groups, and so on. And we tried to replicate the demographic structure of HIV in the UK. So you have mostly MSM, as you see there, but we have Black African heterosexual women, black African women, well, we don't know, black African heterosexual men, white heterosexual men and women. So it's kind of what you would expect out there. They were not completely randomly selected, because that's very difficult to do, but we managed to get from the various places, clinics and everybody else, a representative sample of the populations we're looking at. No, very hard to find them. Well, very hard for them to admit that they were, which is interesting in itself. And I'm sure there are Afro-Caribbean in the UK, indeed, and also black Africans. But we couldn't find them, interestingly. When you look at the figures, statistic figures, and they're not identified. They don't appear as that, at least when we did the study. But the point to make is that of the 100, we're trying to at least reflect what's out there. Okay. The first paper that I'll mention briefly is the quantitative one, where we use that instrument I mentioned before, the WHO brief questionnaire. And
Can I zoom in? The figure you showed on the previous one. Picture, that is the prevalence in UK.
That's the, when you look at exactly, the UK. When you look at the UK, whatever proportion is gay men, that's what reflects what's there. So we tried to reflect what was going on there, not just look at a particular group. So this paper, you can get free open access if you print this later on, but it's there. So the question here was, what affects the quality of life of older people with HIV? So we had that population, we used the instrument, and in that instrument there's one single question which says, what's your quality of life? How do you rate it? And we found that 56% said good or very good, 24 neither good nor poor, 9 poor, and 1% very poor. So 10% poor, but the rest, which is 90%, were quite surprised. But they're saying, well, it's not that bad, which is striking to me. And many said, well, it's actually quite good, more than half. This older population, mixed racial and diversity of all kinds, which was quite a surprise to us, but there it is. So the next question was, okay, can we tell who are the ones that are giving a negative quality of life? What affects quality? So we did first what they call bivariate analysis. We looked at sex, sexual orientation, all sort of items, yes, no, in relation to quality of life score. And this is what we find. Better quality of life, men got better quality of life than women, reported it. And that applied to the total score, physical, independent, environmental, and social. So most of the dimensions, the men gave significantly better than the women. White people, men and women, had better environmental scores, but not on the other items. People with a partner had better total social relations, psychological, quite a few. MSM, environmental and social relations. And speaking as a gay man, there's always the joke, oh, gay men had lovely sitting rooms, hence their environmental reports have been better. You know, beyond that point, the joke, which I can make, but you can't if you're not gay. Again, some better outcome there. People diagnosed being less than 40 years of age, in other words, quite recently, had better quality of life as opposed to the longer-term diagnosis. Not in on the items, but you can see total and so on. People with high education, university education, etc., had physical and independence better scores. People with higher income as well, people not on benefits, on social benefits, on state benefits, had better. And the flip side of that is people working, some of them were working, had better in all domains as well. So obviously it's not that we should stop all benefits and people will be better off then. It's not that way that it works. It works the other way around if you're well enough not in the benefits. But the surprise for us is without grandchildren. My thought was that we had quite a few black African women with children and grandchildren. And what we discovered was that if you didn't have grandchildren, you had better quality of life. My thought had been, here they are, you elderly ladies looking after their grandchildren and feeling so fulfilled. The opposite was the case. And when I asked them, they said, no, I feel freer. I don't have to look after my grandchildren. I have a life of my own, which is very interesting. It was counterintuitive. I'd expected that those women, a few men, but mostly women, who had grandchildren to look after would feel they have a purpose. And if, this is a male thinking in the wrong way about what a woman might feel. But it was very interesting that they said, no, we're much happier without having to look after my kids, about my grandchildren. I can do what I want, which is interesting. So, and that was in terms of independence and total score, and the environmental. The kids didn't spoil their rooms, their flats, etc.
Can I ask, could that be driven by the sample having a lot of gay men who didn't have grandchildren, and they have a better quality of life, which we sort of
I'll answer the question in a second, because we'll say people attending religious services as well had better. When we did the multivariate analysis, looking at everything being put together, then it still appears there, to my surprise. So who had better quality of life? People not on benefits, or people black African ethnicity. Interestingly, we thought that the black Africans would have worse quality of life, but in fact it comes up, men and women, physical, psychological, and spiritual. Again, those were the ones that perhaps had church links as well, in some way. But that was interesting. And MSM, environmental, being partner as well was, as you would expect, a protective thing. And not having grandchildren came up as well. So these are all the, once you've put everything in the pot, all the variables, and try to tease out what's really significant and is not interacting with something else, those were the ones that came up as predicting better quality of life. So just to go back to it, not being dependent on the state for benefits, in other words, probably working, although working didn't come out as one of the black African ethnicity. Again, that may be having to do with what they expected before and what they have now, I don't know. MSM, being partnered, again, we know that from the literature and psychological and social issues generally. If you have a partner relationship, provided it's a reasonable relationship, then you're better off. And then not having grandchildren. So that was interesting. But I think, for me, the main question, the main point of this quantitative study was the very first slide, which is, my quality of life is not that bad. In most cases, they were saying only 10% were really feeling not right. The majority, which is, again, we may be talking about a sort of country where there is access to treatment, a country like the UK where, in spite of all the political tightening of benefits and everything else, people are still getting some benefits and getting some state support, although that's always very difficult to get these days. But in other countries without those elements, you don't know what would be happening, obviously, what the situation would be. So that's the quantitative. What about, oh, there's something else that I didn't mention. We use also the everyday memory questionnaire. You know, all the concern about dementia and HIV, AIDS dementia, which was in some ways a myth because it never quite was as bad as it was thought to be. It was there, but it wasn't as common, and it's kind of disappeared now, unless it's combined with other things. But there's been concern about this, and we've done a number of studies in over 50s coming to the clinics doing screenings with different instruments. And one of the instruments used was the everyday memory questionnaire, which is totally subjective. And you say, how is your memory? Oh, I keep forgetting my keys, or I left the car and I don't know what the car is. Things that we all do in different ways. But so you can look at that subjective rating. When you look at that group, studies, and you look at standardized memory, cognitive assessment, they're not depressed. They're not brain impaired, they're depressed. They have anxiety and depression problems rather than brain impairment. But anyway, we used that instrument in this study as well. And we found that those that gave poor ratings of memory, of their own subjective memory performance, yes, sorry.
So I'm just wondering if you have compared this to a questionnaire with answers from people that do not have HIV?
It's been used elsewhere in other conditions, yeah. and you can pick up people who are concerned about their memory. It's been done with lots of physical illnesses, diabetes, multiple sclerosis, and so on. And clearly, those people, compared with controls, have higher worse scores.
Okay.
Yeah, but I think when you look in detail, certainly in HIV.
But also, like in general, even the
general population.
Ones.
Yeah.
That would
it's
be
been done
really
as well.
Interesting to see the
they're
difference.
not as bad. This is worse.
Yeah.
But what is interesting when you look at them is they're not brain impaired. They are depressed or anxious. They're concerned about their performance rather than having dementia or anything like that.
Okay.
So as an instrument to screen for brain impairment, it was no good. As an instrument to identify people who might be depressed or anxious was much better in that sense. But the point with this is that if you had poor ratings in every memory questionnaire, you also had poor quality of life. So again, it's linked. And worse anxiety and depression, we had some measures as well. So clearly you're looking at a whole host of things that come together: poor quality of life, being depressed, etc., concern about your memory. And again, that may be another instrument that if you're using it to look at screening for brain problems, although it's not very good, medics might use that as a way of alerting themselves. Okay, let's move on to the qualitative now, because in that study we had the questionnaires, which I'm telling you, but also we interviewed 100 people, were interviewed by a researcher, then the interviews are transcribed, and then they're analyzed in detail, and you look at all the contents and so on. So what we want to do is say a little bit about what problems they identified, these 100 people, in terms of coping with, as aging with HIV. But second, and this is going to be the main element, what they found helpful to cope with those problems, what strategies they were using themselves. Now, very brief, that's been published as well, so you can, when you get the copy of the presentation, you can identify the paper. What did we find? What difficulties did they report? Just briefly, mental health difficulties, being depressed, being anxious. Stigma, the interaction between ageism and HIV, feeling very self-conscious about going to places for older people and having to say, well, I'm HIV positive, or not say it, having to hide it. All that element still kind of unresolved, the stigma element. Relationships, either forming them or maintaining them or managing what they have. And again, if you remember from the quantitative study, being partner and having a relationship was a good thing in terms of quality of life. So here you have this group that for some this was a problem, obviously. Financial, housing, immigration problems being identified. And then, of course, as we get older, we develop other illnesses. People get diabetes, arthritis, backache, cancers, all sorts of things. So you accumulate conditions. And that, again, that's another factor that comes here. We can become very focused on HIV, but there's lots of other things going on as you get older that may be relevant. But I want to focus on the strategies, which is the kind of thing that you and I are involved in trying to help. So what did they tell us they were using to deal with older people living with HIV to cope? I'll give you first the list of the items. The first one was reframing the situation, gaining control over one's life, trying to make sense of what was going on. The second was emphasizing the value of relationships. The third one was gaining help and support from external agencies, being able to access support, in particular from other people with HIV, groups or otherwise. Doing things for others came up as a theme as well, and valuing financial security. Now, the way research on qualitative things works, you don't set up what the answers that you want. You look at what's been said, and then you build a picture from what people are telling you. That's important to them. So all these categories were generated by the people themselves, and then we lump them together in this way. So it's not that we decided, gaining control is important. They told us it was. Okay, I'll give you some quotes. This is somebody who describes, this is a gay man. What's wrong with us? We're fit and healthy. We're probably healthier than other people walking the streets now. We're checked every 3 months. We're given £1,000 worth of pills every month. What's the problem? Why are we concerned? So he managed to, this man is an MSM, has managed to reframe his situation, saying, okay, hang on, I'm still here and I'm coping well. Now, if medics said that, that would be seen as unacceptable, but it's him saying it, it's himself saying it, which is interesting. Another one, I like my life. What I had to learn was to stop doing everything. All you need is a roof over your head and be able to eat. This is a white woman with HIV, which is interesting. She's sort of, so, okay, she'd been a businesswoman. She was busy doing millions of things, flying here and there, and all sorts of things. I said, hang on, is that important? It isn't. This is what matters. So I'm retrenching a little bit, but this is a gay man again. I got determined and positive about quality of life when I did a program at the hospital to build strength, sort of physio. I thought I needed to take some control. As you get older, you need to make a rock for yourself. I find new things, little things, like going down to the river at Richmond, just in West London, and having a walk there gives me enormous pleasure. I'm not waiting for death in a room on my own, which is what it could be. So I'm enjoying every day and doing new things. So again, he's kind of turned the picture around. Okay, relationships. I mean, in your relationship, she's one of us, she's positive. She says, I don't have anybody to go to church with. People need a relationship. We need practical and emotional support. This is a black African man describing how through getting involved with another black African woman in a support group, is giving him some sense of we are together now. This is a gay man. I have a life. I have a bloke who loves me, who fights with me every day. I have a sex life. What else do I need? I've been quite isolated for a long time, and one thing I have learned is that I'm not totally isolated because I'm connected to HIV people, and that fundamental connection from one human being to another is absolutely imperative to being alive and finding happiness. Seems a very theoretical and very sort of conceptual way. This was a white woman as well, which is interesting, but no, she's kind of reformulating her predicament in this way through links in practice and in theory. I'm happy because I have kids, black African man, had children, and had managed to bring them over from whatever country he was coming from. Now, of course, we talked about relationships, but then the question of emotional and sexual relationships is a problem for some of them. And from another part of the study, which I'm not going into detail today, the two strategies people were using was either avoidance, I don't get involved. It's not going to work. I don't want to disclose. I don't want to fail sexually. Keep away. Or I look for people who are also positive. And then at least that pressure is off, and whatever happens, whatever we do sexually. So again, there was lots of quotes about difficulties and so on, but those are the main two strategies. Either I get out of the picture, I don't compete, I avoid it completely, or I find someone who is like me and I don't have to hide it. Briefly, this is a study we did some years ago looking at the prevalence of sexual dysfunction in men. There was nearly 800 people, European study, and about a third of men, this was straight, heterosexual, homosexual, various groups, a third of men describe erectile dysfunction of a significant level, and about 20% loss of interest in sex. And you can look at factors. There was nothing clearly related to a specific medication. The longer you've been in medication, the more likely it was. And people over the age of 50 were much more likely to run into problems, as you would expect. But there was no specific one single cause. There was quite a combination of things. And Lena is here, and again, her paper with colleagues, again, looking at not just sexual dysfunction, but also emotional difficulties and difficulties engaging with others. Again, very common in people who are positive. And it's not just simply a question of taking Viagra for the men. It's much more complex than that. It's a huge emotional burden and relationships. Again, very interesting paper to look at in detail. Okay, what about the next few strategies? Support from external agencies. Again, I've got a Freedom Pass and I still get a DLA. These are very British things. Freedom Pass is a traveling card that allows you to travel free. And some people who are physically unwell qualify for it. So he must have qualified as a gay man, MSM, for this. And DLA is Disability Living Allowance. It's a benefit. Many of these things are changing, are getting very hard to get. The state, the government is making it very difficult for people to, they say, oh, HIV has been treated, it's not a problem anymore, you're fine, you don't need anything. So it's that tendency, it's there. But he's saying, well, I had help from the outside, and London Lives helps me. This is an organization that provides practical support as well. So external help. Therapy, I talked to my psychologist about my concerns. This was a woman, black African woman. Again, this is a gay man, that's right. Getting support, getting medication, joining in support groups and so on. So again, having access to support in different ways being a factor. Somebody else. Again, interesting that therapists come up here a lot. People mention quite a few, receiving therapy and support being helpful. But this lady, again, black African lady, she told me cognitive therapy, and when I get depressed, I use it, and I don't need to see her again. I just get on with it. So being resourceful in that sense. Doing things for others, this is interesting too. I'm doing voluntary work, keeps me active. I was teaching people, older people, to deal with computers. I'm an expert in computers, so I'm teaching them. So I'm doing something that gives me meaning, gives some sense of direction. I'm a carer. Now this is, when you read it, it's a bit alarming, because you feel this person has too many needs, which is dealing with by being extra nice to people, and perhaps he needs to stop and think about himself. But you can see what he's saying. Doing things for others helps him to cope. Why not? He's doing something. It may be that he will get burned out at some point if he keeps doing it, but you can see the message. Seeking support from other people with HIV. Again, this is about joining groups and having access to organizations like yours or the various support groups. Black African woman, both of them relying on groups quite effectively. I'm rushing a little bit because I'm conscious of the time. But, okay. And then having financials been safe economically, obviously, is not surprising, but some of them mention it as a specific thing, and not having to depend, and perhaps some of them are working as well. It doesn't come out there. So what I was saying, they recognize their difficulties. We mentioned at the beginning physical problems of all kinds, other issues, stigma and so on. Some are HIV related, some are not. They struggle to manage them, and they cope with them in many ways. And some have developed strategies, as we're hearing here, which are obviously having some effect. And they've done it themselves. They're telling us that's what they're doing. To what extent they always work, or to what extent they are fully effective, we don't know, but there they are. And I think we need to not only encourage, but also evaluate all those self-generated ways of dealing with things, which is not what the doctors or the psychologists say, is what they're telling us, the people with HIV. So I think this is all I wanted to tell you today. So if there is anything else or any other questions that you have. You always have questions. Yes, I do. Please. Yes, please, please. Please do.
No, get out of my head now. You can come back.
Okay. I think it's been a long afternoon, so we can stop soon. I think the message I was giving with the two parts, one is the depression and the mental health, and the aging with HIV, is that essentially depression is not uncommon, and it has effects beyond being unhappy and making you sad and perhaps suicidal. It has effects on your physical health. And it's not that difficult to identify those people. The question is what you do about it, and you need to be well disposed and well prepared and have the right resources. And in terms of the older people dealing with HIV, it's not as bad as we feared. In fact, many, in our sample at least, are coping reasonably well, and they have all kinds of ideas as to how to deal with it. So in that sense, it's reassuring. But I don't know to what extent is the same in Stockholm, in Sweden, what your experiences of older people. Are they fairly well adjusted, some of them? Are they relying on you and then getting on with things? What's your experience?
Well, we could talk about that as well. Is this one on? Yeah, I do have a question, though.
Please.
It would be interesting if you could... I imagine that most of these conclusions are done before the partner study came, who was presented. I mean, we all known for quite a long time that you don't transmit if you're on a treatment.
Yeah, yeah.
But this is also one of the major concerns is not necessarily whether you can contaminate or not, but it's certainly an issue. And so let's say that you would do these kind of studies, and after 10 years' time, has the perspective changed? You know, are people less concerned about transmitting? Are people less concerned being transmitted? Because people are still concerned in older care houses or whatever, and you would meet people that would have they will take things like if they were having a sexual context, you know, where you can't work here with older people because you have HIV, and what do you expect them to have sex with your stuff? And even knowing that you can't even with good medication transmit. So I would like to see this study done again in the future, and then perhaps to see if it has any effect on. Does the knowledge of transmission help you? And also...
I mean, I don't know about Sweden, but in the UK, HIV is seen as a problem dealt with. It's not a problem anymore. So everything is sorted. People take pills and they're fine. So anyway, in many ways, all the educational element of teaching the general public about, okay, if somebody is really with no viral load detectable and is taking the treatment, they will be okay. They don't need to use condoms. They can be... That hasn't quite got to the general public yet. Whether it will ever get, I don't know. I remember reading a while ago an article in the press by a gay man who had used condoms all the time and now was using PrEP, the pre-exposure prophylaxis. And he was describing the experience of, for the first time, not using a condom in a contact that he'd had. And the first time, he just burst into tears. He just felt so bad about it. The sense, oh my God, what am I doing? Although he knew it was okay. But he was in a terrible state. And then the second or third time, he was okay. But you see, even that is in somebody who knows all about what's going on, the emotional load attached to it. that comes with it. But if you look at the general public, the stigma will continue for ages, unless you have the education and say, look, this is okay now. But of course, you need to be very sure that this person is taking PrEP or he's viral load undetectable. So it's an ongoing battle, and my point is that we've stopped educating, certainly in the UK. It's been done. HIV is not a problem anymore. It's gone. So I think that's quite worrying.
Yeah. It is very worrying.
Thank you so much for your facilitation. We appreciate it. But it's mind-boggling that UK thinks that HIV is not a problem anymore, because even if you take tablets and you are adherent and things, all these things you've been talking about take an emotional load. Okay. It's sickness of its own. Yeah.
But I think in the same way in which at the beginning of HIV you had all these terrible headlines in the papers and everywhere else, you know, all this, the gay plague, etc., etc. Now the media's lost interest. They move on to something else. So, and in a way we're very much influenced by the media, and what we hear, what we read, television and so on. There may be scandal and then everybody's aware of it. For example, in the UK now there is a lot of attention, some attention being given to the problem of people with haemophilia, or people who had blood transfusions, who got in the UK, not just, they got Hep B first, then HIV, and then hepatitis C. Although the government said all along, no, this will never happen again, it's happened again. So there's a bit of attention now going on again on the question of a legal case to get further restitution and so on. But beyond that, I don't see much about HIV anymore at the moment in the press, in the UK. And it's that sense that, oh, it's not a problem anymore. Why are you worried about it? And that may be why there's been even little attention given to PrEP, because I thought that the right-wing press, the sensationalist press, might be saying, oh, look at this, you're encouraging them to have sex and no condoms. And there's been limited attention. There was a little bit at first and now it's gone. So in a way, as I said, people have lost interest, moved on. The media has moved on to something else. And when that happens, the public kind of follows, unless you really actively press and argue. So.
It is quite good that nobody, I'll speak on behalf of people living with HIV because I live with it. I think in a way it's good. No one wants to be looked upon as sick or incapacitated. It's kind of good that the masses are being educated about the fact that we live with HIV. There is nothing really. I mean, other people have health issues too. But at the same time, I think this, what you've been talking about, mental health and stuff, should not be disregarded because they take a toll, and also about side effects. Nowadays, there are so many medications that have come up and new, which has not been in existence for a long time. That's also a cause to worry. So many people have developed a lot of side effects, and it's really a challenge.
Yeah, it's about being realistic and understanding what's going on. I was saying at the beginning how people say, oh my God, people aging with HIV, what a terrible thing, all these old people with HIV. Well, that's very good news that older people are surviving. But of course they have problems, so we need to see what the problems are and what we need to do. So it's about having an accurate rather than newspaper-led understanding of things. I think that's the problem.
Good.
Please.
Hi, Pepe. I have a question. In the geriatric literature, they define what they call the young old and the old. And I was aware that your cutoff was 50, and really, as we joked, 50 is not that old, depending where you're standing. But in your data, did you have any sense of the differences, say, between the 50 and the 65?
It didn't come up at all.
Be working,
it didn't come up as a factor.
70-year-olds.
Because we have 87-year-old.
Yeah.
And it didn't seem, the age itself didn't seem to matter. What's how long you'd been positive, that was the factor in that sense. So age didn't seem to matter. So it's interesting. Yeah. There was something else I learned the other day. You were talking about side effects, and I hadn't realized that with PrEP, there's some side effects to PrEP in the sense of osteoporosis, if you keep using it repeatedly. And I wasn't aware of that. All of you may know about it. So you may need to take precautions with vitamin D and various things if you're taking. So it's interesting, things, they're always a side issue to everything, a side effect, consequence. So nothing is pain-free, as it were.
Thank you for your presentation. It was very nice. I just want to comment, make a comment. I talked to some of the people who live with HIV who was older, and some of them tell me, you know, it's so good, you know, because if I look to my friends who are living not with HIV, they don't get the same controls, and I can go to my doctor and I have these follow-ups, but my friends who doesn't live with HIV, they don't have it. So, and they say, I have really nice values and everything is looking great, and but my friends who doesn't have HIV have a really bad shape or something else. I think it's good to turn it around as you told.
To be realistic as well, because not everybody will be as fortunate as that, but some will have friends, and we need to be aware of it and not assume that everybody's fine. So there is, I'll just mention very briefly, in the social science literature, not just in HIV but generally, there is a lot of debate about the neoliberal view of aging and death. And this may be familiar to you. Neoliberalism is a sort of economic and political view of viewing the world. It began with Reagan and Thatcher, and now everybody is neoliberal, which means the state is very small, and it's all up to individuals. It's up to you. You can survive, you try hard enough. Nothing to do with the state, that model. What is economically neoliberal now has been translated into other areas. And think, for example, of obesity. People who are morbidly obese. It's very easy to say, well, aren't you lazy? You should be trying harder, eating the right thing, But if you take a sort of non-neoliberal, that's a neoliberal view, it's your fault. But if you look at the context, these people are people who may have less access to healthy food, the educational factors play a part, they come from areas of unemployment. It's a global issue, it's not an individual fault. The neoliberal model that is up to you, slim ladies in the 80s who go to the gym 3 times a week and so on, they can afford to do that. So you know what I'm trying to say. And it's the same with aging and with death in HIV. There is this debate now about dying well and aging well. Well, we're all going to die. So somehow to say, if you get sick and die, it's your fault. They're not saying that, but that's the theme. You need to be very careful. Hang on, there's global issues and contextual issues that play a part in how we age. And the idea of aging well, you're getting caught into this neoliberal model that says, it's up to you to age well. If you don't age well, it's your fault. When it's much more complicated. You've got, access to resources, access to treatment, educational abilities to that support at home. So we need to be very aware of that risk of, we need to age well and we need to die well. Of course, we want to do all those things too, but in a wider context, not just as pointing the finger at you and saying it's up to you if you age well or die well. And of course, in HIV, people still die. And what's happening now, we've been doing some work on the narratives of death in HIV in the 30 years that we know about it in the UK. And what is interesting is that when you look at now, in the early days, everybody talked about death, and you went to see the doctors with your living will to have plans as to what to do if you died. Now it's not mentioned. For the doctors, it's failure if you die, because we have all the treatments, you shouldn't be dying. And for the people with HIV, there is a risk of that happening too, to some degree. So somehow, death is pushed out of the picture, somehow. Well, we need to sort of bring it into life as well. And it's one of the consequences. Okay, you can struggle, but you'll do your best. But then we need to, don't deny it. It will come. That applies to HIV and to everything else, to all of us. But it's very tempting within the HIV world to pretend death is not happening anymore. It's happening. People kill themselves. People take drugs that kill them, recreational drugs. So it's interesting. So we get caught into this whole paradoxes of success and the neoliberal sort of emphasis. And I will stop now. Okay. Oh, yeah, exactly. Yeah. Stigma is interesting. Yeah. We were talking to a community nurse, I can just say one thing, dealing with people with HIV in Liverpool, of all places, and she was describing the case of a young man who, I think he acquired HIV vertically, but he now is terrified of going to the HIV clinic because he doesn't want anybody else to see him going there. So the community nurses go and give him the medication 2 or 3 times a week at home. And the point that the nurse was making is, HIV won't kill him, stigma will kill him. So it's still there. So, yeah, I'll do stop now, yes.
Well, thank you very much, Pepe. I think your presentation, just like Lorraine's presentation, really have given us a lot of considerations and concerns, and I think there are many, many similarities between the UK and Sweden in terms of the consequences of living with HIV infection, both for women, men, and children. And it's very, very important, of course, that we keep going and really continue our struggle. It's not over, although we do have the pills, but that's not the end of the story.